Someone wrote it down somewhere along the line, so as we go through it. Pretty short one, only takes maybe about 2 hours today if that, so we'll make it through pretty good. A lot of slides, but we'll skip through some of them, so as we go through it. So we're going to talk about various infectious diseases, talk a little bit about our policy, talk a little bit about your policy as far as what you guys do if you have a exposure, if you will. We're going to talk about what the hospital does, what you guys are going to do, and what you should do as an individual paramedic. So, now a lot of these diseases are contracted various different ways. I mean, they can be through direct or indirect. Someone coughs, the air particles, the droplets in the air, you re-inhale them, can be an issue. Getting blood on an area of an open wound or in a mucosal membrane might end up being an issue. And then there's also bugs out there that will give you some type of communicable diseases. Now, depending on if you are going to be infected and end up with the disease or not, depends on a lot of different factors. How were you exposed? How long was the exposure period? How healthy are you? And how sick the patient may have been. You know, someone that's maybe just has, just been diagnosed and maybe their levels are pretty low, you may not end up with it as readily as some of the other ones. Plus also the incubation period, when is somebody contagious? Those are all different things that are going to make a difference. So we'll start off with the HIV. This is transmitted blood and bodily fluids. Takes about 7 days and to show up, and it can take even sometimes longer than that for it to become one of those things that you're finally going to be aware of. We don't know what the communicable period for HIV actually is. You know, originally we thought HIV was going to be the disease back in the 80s that wiped out the population. Kind of like what happened when Ebola came around. It was going to be the next disease that wiped out the populations. So what kind of signs and symptoms do you see with someone with HIV? Mostly flu-like symptoms. They're sick, they've been tired, they have maybe some swollen glands, febrile, or they could be afebrile, either one. But we usually see this in patients that have already started to get sick. It's already taken within their bodies. And this can take up to a couple months to actually show. Now, how do we treat or how do we deal with patients who have HIV? It's no different than any other patient you deal with. Interesting enough, I know this is going to drive a lot of people nuts because we were always telling you guys, every single patient, use gloves. Don't touch a patient without it. The CDC now is actually recommending not using gloves as often. Some of the things that they're recommending, even as far as vaccinations, you don't need to have gloves on. Now, I don't know about any of you, but a lot of people are not going to go ahead and give a patient a vaccination without having gloves. There are some things that are different from hospital to EMS or in general, and they do say for EMS, yeah, we may recommend it, but it's not one of those things that is like what we used to push years ago. The other thing is making sure you're using good hand washing techniques after you've gone ahead and dealt with the patients. We're slowly switching over to the needleless systems. I mean, you see that. Do you guys have the needles when you need to drop a medication out of a vial? Do you guys have needles or do you have the blunts now that you're using? Does anybody know? You guys on the rigs here? I know at the hospital they do. The blunts? Yeah, blunts.
Like a mouse. What is 420?
Yeah, it is 420 today. That's right. Yeah. So, when's the last time you guys fully decontaminated your rig? Somewhere back in the 90s, maybe?
Bojo's steam cleans it every shift. That's right. He's on it, man.
He was saying that. You're a good medic, Bojo.
Yeah. I mean, most of the time we'll wipe down the cot if we have a patient who is wet and sticky, and those types of patients, they kind of get clean. But to take things out of the cabinets and re-wipe all of the inside of the cabinets down. How about your blood pressure cuffs? Your stethoscopes. You know, when are the last time that people really went ahead and took the time to decontaminate them or clean them? And then again, how are you doing it? You know, you guys spray the Cavicide on your cots and then immediately you wipe them down. You need to go ahead and then dry it off and let it dry to make it be effective. So, AIDS incubation period between the documented infection and the development of the end stage of the disease. Again, communicable period is presumed to last as long as the patient is positive or showing positive signs. Some of the signs and symptoms here, or some of the other diseases that they may have, and I'm not going to go into all the different types, but there's different types of pneumonia and TBs and meningitis, and herpes is on there too, as far as one of them that AIDS people will end up getting. Again, a lot of different medications for these patients now. Antiviral medications are being given, and patients with HIV and AIDS are living a lot longer. Now, if you guys are exposed to someone with HIV, you may not actually get a lot of the regimented treatment. There's different levels based on what their blood levels show, what your blood levels show, whether or not you will actually get treatment if you are exposed. This is just a picture of someone with eczema inside the mouth, on the face, and inside the mouth from AIDS. So, had to throw in a gross picture there for a little bit, but yeah. So these three drugs, I'm not going to pronounce them because I can't, but just notice them because you probably will see them later on today. But these are the three medications that are mainly given to patients with HIV. So if you can remember these three, you'll get at least one right on the quiz. So what happens when we get exposed? So you're on the back of an ambulance and a patient spits on you. Is that an exposure?
Where does it go? Yes.
Where does it go? Good question. Well, if it's just on the side of the face, on the cheek, not in an area where you have broken skin, it's technically not considered an exposure. Now it's gross, I will tell you that, but it's not a significant exposure. If it goes in the mucosal membranes, the eyes, the mouth, the nose, then we consider it exposure. Do you have, or who at your department is your designated infectious control officer? Do you have one?
Next question.
So no one here has gone to the wonderful, stimulating 48-hour class on infectious diseases, to be known as the Department DICO. Chief A couple years ago, the state of Illinois started putting, it's probably been now about 8 years, but they put out this class for designated infectious control officers. And people from each department would go down, they'd take this class, and they were the one person that was going to be for their department, which was rather difficult, especially on departments that did 24/48s, because they need someone who's going to be available 365 days a year, 24 hours a day. And so if there is a significant exposure or any type of exposure, that person is the one that is going to make the determination. Sure, it's significant. Yes, you need to go be treated or tested and then treated maybe. Or no, I'm sorry, not a significant exposure. Yes, it was gross, I get it, but you know, we're not going any further with this. So that's what they were mainly being trained for. Also, it was a person that if there was a significant exposure, that person then would be in contact with the hospital. They would be the one that would get the results of the or get the results for that person so that they could go ahead and relay them back to them. To be honest with you, I know that our policy, and we'll talk a little bit about our policy later on, but you're supposed to let us know at the EMS office. Really, we have nothing to do with it. It shouldn't be any of us. That would be technically a HIPAA violation if you guys had a significant exposure and your blood work came back positive. For us to know, it's none of our business. It should go directly to you or your designated infectious control officer. So what they look at is they look at various things, and I'm just going to kind of, I know this is really, really small, But they determined the exposure code. Was it a small amount of fluid or large amount of fluid that got into you? Was it something that was like a needle stick that went right into your blood vessel, or was it something that was just on unbroken skin? And those are the things that they'll start by looking at. And based on the exposure code, you're given an E1 through an E4 code, or EC1 through EC4 code. And then they take a look at the patient, and they look at the HIV status of that patient itself, and then they give them a code. And based on the two codes together, that will make the determination whether or not you receive treatment for these patients. Now, who does your OC Health? Is it Evanston Hospital, or do you guys go somewhere on the outside? Do you know? Okay. If you have a patient that you are treating and you end up with some type of exposure, please make sure that you are checking into that hospital where you take that patient. It's a lot easier when they can draw the blood and you are right there, that you can have your blood drawn, and so they can match up the blood so they can give you the results. But going ahead and having the patient and then you guys running over to a clinic for OC Health is a little bit more difficult to try and match up the blood. They're not as apt to give results to you when that type of situation happens. So making sure you check in. We actually changed our policy for cardiac arrest. If you have an exposure on a cardiac arrest victim, they actually want you to transport that patient. Even though the fact that you probably were going to call it in the field or ask to withdraw resuscitative measures in the field, they still want you to transport that patient, because then they can test the blood. And then they can go ahead and let you know and test your blood right off the bat too. So based on this, they'll go ahead and determine what type of treatment. Some might just receive a very basic regimen. Some might receive the extended regimen treatment for these patients. Hepatitis is another one of our main concerns, and it was hepatitis B. Hepatitis A has been coming around though. They say, you watch TV, that anybody in that baby boomer age over 50, you should actually be tested for hepatitis C, because they say that a lot of people over the age of 50 do have hepatitis C and they don't know about it. Hepatitis C used to be pretty nasty. It used to be one of the #1 reasons why people were on liver transplant lists. Now there's evidently some medication that you can take that will cure you of hepatitis C. We go ahead and we get the vaccination for our hepatitis B if you so desire. There is now a vaccination for hepatitis A. Let's go here. Hepatitis A is transmitted through the fecal-oral route. Someone goes ahead and goes to the bathroom, they don't wash their hands, they start eating, they can end up with hepatitis A, or if they're making and preparing someone else's food. Now, one thing about hepatitis A is it's pretty benign. It usually goes ahead and cures itself after a couple weeks on its own. Incubation period, 2 to 4 weeks. And the only time that you are contagious is when you are showing signs and symptoms of the disease. Period of end of incubation to a few days after being jaundice. What are you going to see with hepatitis A? Well, flu-like symptoms. They're going to be tired, fatigued. They may have a fever, nausea, vomiting, abdominal pain, are a lot of the things that you see with phase 1. And then it can go into phase 2 where people start to get a little jaundice. But it will resolve itself on its own after several weeks. Hepatitis B, we are seeing with blood transmission or bodily fluids with blood in them. Usually people who get stuck by a needle are the ones with, that end up with hepatitis B. Incubation period can be up to 200 days, so it's quite a long time out there. One other thing about hepatitis B is it lives outside the body for 7 days. So you get blood on your nice black boots, on the shoelaces, and you've got dry, cracked skin, and you run your hand over that blood, there is a possibility that you could have been exposed, because it does live outside the body for such a long time. Here's a picture of someone being jaundiced. Some of the things that people get: loss of appetite, abdominal discomfort, yellowing of the eyes. So, hepatitis C, we used to say people got it from having, getting tattoos from dirty needles, but blood-to-blood contact, even sexual contact could be a person who can spread hepatitis C. People also can be carriers of the hepatitis virus, but really show no signs and symptoms at all. Hepatitis C can live outside the body for 3 days, and the incubation period is about 2 to 24 weeks, so quite a long time. And like I said before, it used to be one of the reasons why people had liver transplants. It was something that was pretty uncurable at the time. Signs and symptoms are like all the other hepatitis: the nausea, the vomiting, the abdominal pain. Anybody have any questions about hepatitis? How often do you guys get your titers drawn for your hepatitis? Is it when you guys get your physical, or every couple of years? Never? They really recommend after 10 years having your titers drawn, just because of the fact that they want to see if you still have the antibodies in the body. If you don't, then they recommend that you go ahead and have the vaccine again. They used to have a booster out there. I don't believe they do the booster anymore. I believe they just do the whole series all over again. And that's like a lot of the other vaccinations. The MMRs, the DTPs, those types of vaccinations, usually when you get into your 30s and 40s, they recommend having your titers drawn, just because of the fact that you may need to have those vaccinations again. All right, lots of different types of pneumonia, inflammation of the lungs. Most of them are not communicable. We see in pneumonia patients a lot of times in our older patients, and especially those patients that have been hospitalized for a period of time, those that have been intubated. Of course, you're chronically ill. Those that have immunosuppression are going to be at high risk for it also. And then our peds patients. Some of the signs and symptoms you see with pneumonia: fever, chest pain, difficulty breathing. But remember, you don't always have to see those signs. That's why when you have a patient who is having difficulty breathing, maybe wheezing, rales, you want to ask questions like, have you been feeling bad for a couple days? Have you been running a fever? And that can help make the determination if it's heart failure or if it's pneumonia. The other thing is, ask about their cough. Is it productive? Are they coughing up something? What color is the gunk that they're coughing up? Kind of leads you down to believe if it's pink frothy sputum, it may just be heart failure. If it's some type of mucus, it could be bronchitis, pneumonia. Antibiotics are used to treat the bacterial pneumonia. And then too, some of the things that you might want to watch out for is watching someone to see if they are sepsis. Remember, our sepsis, we look at heart rate, we look at respiratory rate, we look at temperatures. I know you all have thermometers on your ambulances that you can take temperatures on a regular basis, right? So if they do, consider the sepsis protocol for these patients. Meningitis is the next one. It can either be viral or it can be bacterial. There is a vaccination, and they usually give it to kids in that high school area or age range. Moving on to colleges, we see a lot of times groups of people together are more likely to end up with the meningitis, because it ends up being like an outbreak or an epidemic for these patients. The bacteria is in the back of the nasal pharynx, in the back of the nose, and it's transmitted anytime someone sneezes or coughs, and it goes airborne, and then you come in contact with that. Contact time of 8 or more hours, so people that live with each other. So you've got college roommates living together, and they're more likely to end up with meningitis than those that are living apart. Incubation period can be up to 10 days, and the communicable period is really variable for these patients. Now, some of the things that we look for, besides flu-like symptoms, we look for that nuchal rigidity. Can they drop their chin down to touch their chest? If they can't, their menses are actually irritated. And there's other signs like the Keurig sign, where they go ahead and they lay someone flat and they lift their leg up, and if they can do it without bending their leg. I don't know how that works, because I can't straighten my leg either all the way. Or Burdinsky's sign, neck sign, where they go ahead and they lay them flat and then they put the head up and do the knees pull up. Those are all ways to irritate the mentions of the brain and the spinal cord makes it very painful. But some of the things, fever, stiff neck, not feeling good, are very common. You have someone who has meningitis in the back of your rig. You want to make sure that you're putting a mask on them. Maybe even you guys going ahead and pulling out your N95 mask. Make sure that you're decontaminating your rig afterwards, so that anybody that may come in contact with it later. Treat your patient's signs and symptoms. We don't have a meningitis protocol, but we do have one for sepsis. We do have one if they're dehydrated. We can go ahead and give them fluids. They're having difficulty breathing, maybe some oxygen. Tuberculosis, another type of disease, they say not highly communicable. Honestly, I don't know the answer to that. I always thought that it was pretty contagious if groups of patients were together. We see this a lot of patients that are living together, homes that have multiple persons living there, someone who's undernourished. Our lower social economic areas are very high risk for tuberculosis. It is transmission by airborne particles, and then the incubation period is up to 12 weeks. You guys have TB testing probably, what, once a year when you guys have yours? Are you guys doing the blood test, or are you doing the skin test? Skin test? Yeah, they have a new test, and I think it's called Gold's, something or another, I don't remember the whole name of it, but where they can actually test through the blood. Once you've had a positive skin test, a lot of times they'll go ahead and have you do a chest x-ray. And what they're looking for is the lesions on the lungs. And you are technically only contagious when you do have the lesions on the lungs. Some of the big things to look for or be identifiers, someone tells you that they wake up in the middle of the night and they're drenched wet. You know, they're having those night sweats. They're coughing up blood. They've been sick. They've been fatigued. They have a hoarse voice. Some of the things that you want to be aware of. Again, if they have tuberculosis, go ahead, place a mask on your patient. You know, you don't want those particles flying around the back of the ambulance. If they need oxygen, go ahead and, you know, apply it, but do it with the form of a mask. If you come in contact with someone who may have tuberculosis, let in your designated infectious control officer that you have here know. Okay, following your chain of command, and then making sure you're deconning your rig afterwards. RSV, another type of viral contagious disease. We see this with direct contact, large droplet. Incubation period is about 2 days to 8 days. And again, making sure you're washing your hands, making sure that you're not touching all sorts of things. And then your gloves are all contaminated. Signs and symptoms just look like a regular cold. Sneezing, runny nose, coughing. But if it's not taken care of early, it can lead to bronchitis, pneumonia. And we see this a lot of times in those younger children, and a lot of them will end up hospitalized. So again, with these patients, make sure you're using proper PPE, using the masks, making sure that you're decontaminating your rig after each and every patient that you might come in contact with. And then two, if you guys are contaminated, make sure you're following up with what the doctor recommends as supportive type care. Neurovirus, a lot of time winter flu. We see this a lot. If you have nursing homes in the area and one person gets it, everybody seems to get it. Now there's a lot of these diseases here that are not affected by the hand sanitizers that you guys use. How often do you guys wash your hands with soap and water throughout a day? Or do you use the hand sanitizer more than you actually use your hand washing?
Well, Joe washes his hands with the hand sanitizer and soap.
Hand sanitizer is okay. The CDC tells us that there's things like norovirus, C. diff, that the alcoholic-based hand sanitizers do not get rid of, or the germs it does not kill. They recommend using just plain soap and water, and not even antibacterial soaps, because the antibacterial soaps that the CDC talks about is that they get rid of the good flora as well as the bad flora, and then they become resistant bacteria or resistant germs. So they recommend just soap and water. If you do use the hand sanitizer, it works for someone, you know, the standard, I've gone and I've touched a patient, I just want to kind of make sure it's clean, but norovirus, C. diff, there's one other one, and right now it's leaving my mind of what it is. I'm sure I'll come in contact here later with it. But making sure that you are decontaminating. A lot of times nursing homes or assisted living centers, they have a patient with norovirus. Hopefully they're at least notifying you guys when you get a call there. And I know that some of them will actually shut down. They don't let outside people in or out if they can go ahead and help it because they don't want it spreading. But it's ingestion of contaminated food or water. When someone goes ahead and goes to the bathroom, the diarrhea ends up being kind of airborne particles. And that gets into, yes, into the air. It's not why, same reason why you're not supposed to use those air blowers for your hand, drying your hands anymore. It sends bacteria, fecal material throughout the, yeah.
Like terrors.
So, yeah, aerosols created from vomit and diarrhea. Symptoms appear pretty quick for these patients. And the big thing we're concerned about is them becoming dehydrated. So, forceful vomiting, watery diarrhea, weakness, low-grade fever. You come in contact with these patients. Obviously, making sure that you're well-protected, gloves, making sure that when you're leaving the back of the ambulance, take your gloves off, don't drive with your gloves on. We see that every so often. People pull into the ambulance bay and they've still got their gloves on, unless you put a new pair because you don't want to touch the steering wheel for some reason. Making sure you're using good hand washing techniques, soap and water, not the alcohol base, because like I said, it's not gonna get rid of the norovirus. Chlorine is the only thing that really is effective for the norovirus or C. diff, and we really are not going to go washing our hands with chlorine-based products. So, let's see here, vector-borne, ticks and mosquitoes. West Nile virus, I don't even know. Do we have counts of West Nile virus in here? Do they do that in the summertime? Do you hear people end up with it? A lot of people are not symptomatic if they end up with West Nile virus. Only 20%. Fever, headache, body rash, even swollen lymph nodes for these patients. So, if you have a patient with West Nile, make sure you're using the safe needle devices. Let your designated infectious control officer know that you've come in contact with someone with West Nile, but you're not going to get any follow-up treatment. There is really no follow-up treatment for it. Lyme disease, transmitted by ticks, not transmitted person to person. Incubation period can be quite long. The thing about Lyme disease is, yeah, you may end up with that bullseye rash, but after it goes away with the antibiotics, it can come back or stay dormant in your system for many years. A lot of times people who have had Lyme disease may count 5 years down the road that they've got arthritic type feeling. People are usually diagnosed with fibromyalgia later on in life after having Lyme disease. There's actually a company, healthcare down in Chicago, that's doing a lot of studies for Lyme disease, and they're finding that the antibacteria or the antibiotics are not curing all of the Lyme disease signs and symptoms. But there's a new study that they're doing. They're sending them to Germany, and they're undergoing some other types of treatment, which I right now can't remember what they are, but they're actually curing these people of Lyme disease, and they're not having the muscle aches, the joint pain from it, the heart problems that people usually do have later on after having Lyme disease. So early on, they're going to have round red lesions. Arthritis and joint pain is a very late sign. Other things too, they can have long-term depression, dementia, flu-like symptoms, fever, aches, pains, chills are all right away we see people. There was actually just a article done with stevia, the sugar substitute, that has actually they've been working with to see it kill other parts of the virus that the antibiotic is not covering. So I know they're doing more research with that. I was just reading an article not too long about that. Heart complications, heart failure, chest pain are all different signs and symptoms of Lyme disease. Then we have our infections that are resistant to different types of antibiotics. A lot of this is attributed to the overuse and misuse of antibiotics. You know, people take their kids in and their kid has a sore throat, an earache, and it's not a bacterial infection, but they want an antibiotic for it. They want something to give to their kid because they think it's going to make their child better. And they're finding out that we're overusing or misusing antibiotics. So this is MRSA. MRSA is usually transmitted via unwashed hands, and people that are at risk for having MRSA are those that have been on long-term antibiotic therapy. Now there's a couple different types. You have your hospital-acquired MRSAs, and then you have your communicable MRSAs. There is, on the tables in front of you, we have the communicable MRSAs. It's all over that if you would actually go ahead and test it. But because we're actually fairly healthy people, it really does not affect us. We don't get sick from the tables or come in contact. Patients that are in the hospitals for long periods of time may end up having MRSA. And that actually is a great financial burden on hospitals, is patients that do get infections while in the hospital. So they're very careful to make sure things are disinfected and clean. I actually had a kind of, found it fairly interesting. My son spent a couple months down in Honduras at a clinic in a medical mission trip down there. And his first day, he was handed a bucket of water, a brush with rubber bristles on it, and a bar of dial soap, and told to go clean wounds. And he's like, okay. So he went and did that, cleaned them out. He's like, do we cover it with antibacterial ointment? Do we give them an antibiotic? What are we going to do? And the doc's like, nope, send them on their way. He's like, okay. He had a couple other instances. One, a woman was getting ready to have a cesarean. They washed her tummy with dial soap. And he's like, no betadine, no. And they're like, nope. They didn't even use anything to clean the areas before they did a lumbar puncture, or they did stitches and things like that. And I says, well, gosh, what is their infection rate down there? He goes, so he went back to the doctor that he was working with, and he said, in the year that he was there, he only had 3 cases of infection. So, but their bodies too, they're used to it. Their bodies have built up resistance to a lot of the bacteria down in the area. You know, we go ahead and we try and kill them with antibiotics. So he says, like, the hospitals down there were just filthy and pretty disgusting. So part of the staph infection with MRSA too, people end up with boil or lesion type things on their body. All of a sudden you may have come in contact with a patient and months later end up with something that looks like a spider bite, a little white dot on it. Maybe it starts off the size of a nickel, and as the days go on it gets bigger and bigger until it's, you know, huge, and it's warm to the touch and it's red. And they have to go in and drain it and then put a drain in it just so that they can kind of get rid of those boils. But sometimes, just MRSA too, just is not in wounds. It can be in the respiratory tract. It can also, I believe, be in the intestinal tract. Communicable time varies. Incubation period, 5 to 45 days. So, secondary infections usually occur after some blood type infection. Vaco-resistant staph infections, those that are at risk again, those who have had previous MRSA, those that have indwelling catheters, Foley catheters, PICC lines, they're all at risk for it. And those that have had any recent exposure to vancomycin. Some of the signs and symptoms that people are going to see again are those abscesses, those boils that automatically appear on the body. They could end up with cellulitis. Maybe just their skin starts getting red and it looks kind of like a rash and it starts to work its way up the body. Body weakness and body pain, and also meningitis are some of the other signs. So, yeah, they can go ahead and treat it with linezolid. I cannot pronounce medications, but found in the respiratory tract and bloodstream is pretty common for these infections. So some of the things that your patients may present with, along with fever, difficulty urinating, burning when they urinate from UTIs. Any areas, take a look at to see if they have a catheter. Is it red? Is it warm to the touch? Does it look like it's infected in certain areas? Take a look at the surgical wounds. If they're post-surgery and they're at home and they're bandaging up their own wounds, it's not a bad idea to just take a quick peek at it just to make sure that that's not the wound or that's not the course of the problem there. C. diff is another one of the famous and can be actually fatal type diseases, but it's a spore-forming bacteria that causes diarrhea. Again, this is not killed by alcohol-based hand sanitizers. Soap and water is what you need to be able to wash off your hands real good. Resolves usually after 2 to 3 days after you discontinue the antibiotics, but it is contaminated with any surfaces that may have any fecal material on it. And again, those that have diarrhea, you go to the bathroom and someone has diarrhea and it aerosolizes in the air, and it could end up on lots of different types of surfaces. So signs and symptoms, diarrhea, you can usually walk into a home and smell that someone has almost C. diff. They have a loss of appetite, maybe nausea and vomiting, and some abdominal discomfort from it. Make sure you're using good hand washing techniques, using gloves, deconning the back of your ambulance after your patient has been taken to the hospital. Make sure you're cleaning your cot. If you have any areas of open sores, open wounds, make sure that you are, if you come in contact with it, make sure that you're letting your designated infectious control officer know if you have any contamination. And again, this one is too, chlorine-based type cleaners are what you need to go ahead and kill off the spores. MERS is another one. I don't know how many people are dealing with bats and camels, but yeah, MERS is another respiratory ailment. Most of the time, it's people become infected after having contact with camels, so make sure you wash your camels or keep them clean. Yeah. Fever, cough, shortness of breath. 3 to 4 out of every 10 people with MERS actually will die. Okay, so it is pretty bad disease, but some infected people had mild cold symptoms or even no symptoms at all. But most of them are the short of breath, the cough, and the cold. All right, Ebola, we actually spent how much time and energy going through and planning and prepping for Ebola and making sure that everybody was safe. We put in disaster plans for patients that we thought may have Ebola. I remember you actually had one person here that didn't end up having it, but he came back he had traveled, it was flu-like. I remember you guys didn't transport him, you left him there, right? Is that it?
No, we transported him.
Oh, you transported him?
Oh, yeah. We wrapped the ambulance all up.
Well, and ambulances were like making Ebola ambulances where they were putting plastic in.
That's what we did.
Is that what you did? Because I know that you guys had it over there and there was something, I was there that day. And I must have left because I didn't know you had transported them, but it wasn't like it was an emergency. You picked them up and you left right away. You took some care.
Actually, we were there for like an hour.
Yeah, we
Set
had
up.
decon and everything.
Chief went in with the whole get up on and.
Yeah?
You mean when he came out?
Yeah.
Why came right over the cell phone? Came back out.
Oh, that's right.
Yeah, Bluetooth.
Yeah, because, I mean, they were having, what are they, Class B hazmat suits that they were having you guys use?
That's what we use.
That's what you guys used? Okay.
I just stayed with the ambulance and decided
Yeah.
Go in with it.
It's being transmitted by unprotected contact with bloody or bodily fluids, urine, saliva, feces, vomit, sweat, or semen, and coming in contact with anybody who has any of these signs or has been infected with Ebola. You know, even at the airports, they were asking people, you know, where are you coming from? Do you have a temperature? And I don't know what, I know Milwaukee though, they were actually taking the temperatures of some of the people. I don't know if O'Hare was doing that, but they had special hospitals that if they were coming in by plane, they were immediately taking them over to certain hospitals too, so. But this was gonna be the disease, the next disease that was gonna wipe out the population. Some of the things we looked as you've been traveling in the last 21 days, and do you have a fever? Did they have signs and symptoms of Ebola? And have you touched someone who has been sick with Ebola? And that's kind of what they were looking at as far as transmission. So the incubation period ran from 2 to 21 days. Most likely, signs and symptoms emerged after about 8 to 10 days. Anybody that had signs and symptoms was automatically stated to have Ebola. And they did. They put them in special rooms. They wrapped ambulances in plastic. You know, they wanted to make sure that everybody was safe. And then they had special waste canisters in order to get rid of the medical waste and anything that was come in contact. And they paid a lot of money to go ahead and have that removed. So patients without signs and symptoms were not considered to be contagious. So if you were caring for someone, you wanted to make sure you avoided any contaminated needles or any other sharp objects, which is a good thing. Avoiding anything that had blood on it or any other bodily fluids, because you didn't want it to come in contact with any of your skin, mucosal membranes, eyes, nose, mouth. So, yeah, and we, like I said, they wrapped the patient up pretty good. Providers were in hazmat suits to make sure that they were come in contact. They were being decontaminated after they were done, just to make sure that they were cleaned off. Some of the illness can cause delirium or erratic behavior. That was also another concern, because was the patient going to act out? Was the patient going to cause some type of harm to you as you were trying to care for them? So they were looking at fevers greater than 100.4, headache, muscle pains, nausea, vomiting, diarrhea, abdominal pain, and anybody that had any unexplained hemorrhage. So, just as a real quick note, I'm having a squirrel moment here, but have you guys been passed on the information about the new K2 spice with the rat poisoning in it? Okay, yeah, anybody that's taken any type of drugs with unexplained hemorrhage are set to bleed, yeah. We just got some information from it that, well, vitamin K is what they're using to treat it, and what is it, normally 8 to 10 milligrams of vitamin K is used for patients that have, but they're using anywhere from 150 milligrams of vitamin K, and it's costing almost $8 to $12,000 a day to treat these patients. So we don't have any long-term information, because as soon as they stop bleeding, they check themselves out, and they're not really apt to come back and give us a follow-up. So we're not getting a whole lot of information. A lot of them are using it because it doesn't show up on drug tests either. So, all right, sorry, back to your scheduled program here. So other things, yeah, we just went through this. Residents in or travel to a country where there is an Ebola breakout. If you come in contact with bats or non-human primates, also a concern. Okay. Big thing is to let the hospitals know, and you guys did a really great job when you suspected that you had a patient. I do remember you guys called up to the hospital right away, because the ER called up to us to let us know that we might have had a situation with this patient. So that's exactly what you needed to do. Let the hospital or the receiving hospitals know well before you get there, so they can go ahead and be prepared. Let's see here. Yeah, this is just what they talk about, making sure you've got good barriers, tarps to protect non-essential equipment from any contamination with any bodily fluids, limiting the use of needles and sharps as much as possible. So, initial, the CDC recommended, like the first picture here in red, the revised recommendation is that you were wearing, the whole getup if you were dealing with any patients. Big thing is that after you had come in contact with an infected patient, that you were able to be decontaminated, and making sure that you were removing things correctly. Obviously, removing your gloves being one of the last things. Washing hands frequently between steps of doffing the PPE until all of your PPE is removed. So, making sure you don't contaminate the eyes, the mucosal membranes, or clothing with potential infectious material. So, the other thing too, making sure you're using proper airway. If you're intubating someone or suctioning, making sure you're using your goggles, maybe face shields or even face masks. Using your N95 mask if you have someone who is coughing, should be used. Double gloving is what they recommended, but not limited to. Disposable shoe covers and sometimes light coverings for these patients. So. All right, if you are contaminated, if you have an exposure, one of the things they recommend is that you stop working immediately, okay? If you have a contamination, maybe you have a needle poke, maybe you were in the back of an ambulance with a patient who was coughing that had TB and you didn't have a mask on, making sure that you let your infectious control officers know, or at least someone here of authority to know. Making sure that you're following up with health, making sure that you're getting tested as soon as possible. Making sure that you're washing your hands good with soap and water. And this just talks a little bit about the disposal of the medical waste that they actually had to do. They called it hazmat materials and follow the hazmat regulation guides. So. And there were special permits that they had to get, and hospitals were able to get them fairly quickly. So what is your responsibility? Well, if you are coming in contact with someone who does have some type of infectious disease, first of all, letting the hospitals know. Alex, do you know, do we have a negative pressure room down in the ER? Is that back room?
Yes, we have two.
We have two of them. What rooms are they offhand? Do you remember?
10, either 11 or 12 or 9 and 10.
I know it's 9 and 10, but they change things around down there, so I'm not sure. But yeah, letting the hospitals know so that they can prepare these rooms. Really, they should have some type of outside entrance to some of these rooms. Our ER obviously doesn't. Hopefully that if we ever decide to redo it, they'll do it correctly. They actually had plastic up for the longest time as making the room resistant. It was kind of funny, but making sure that you're taking a look at your equipment too. Your stethoscopes, your blood pressure cuffs, cleaning them, spraying them down with Cavicide spray, and then letting them air dry. Cleaning the walls down and the cot, making sure you're disinfecting. New linens for every patient, I think that's pretty common. Making sure you're washing any area that may have been contaminated. Okay. Yeah, I think, and again, the Cavicide wipes, they actually recommend 10% bleach solution rather than some of the, like the Cavicide wipes. The bleach solution is going to do better on some of those other areas. I think they have it listed somewhere here, but do you have a set policy for decontaminating your rigs here if you come in contact? Does everybody have access to your infectious procedure if you're infected or you're contaminated or you have an exposure? Do you have access to your exposure control plan? But you know someone who does. So this is the one I was telling you about from the CDC here. You know, whether or not to use gloves or not. Drawing blood samples, not recommended by the CDC, but recommended for EMS. Same thing for injections, not recommended by the CDC, but still recommended for EMS. And then it tells you all different types if you're going to use gowns, masks, or even protective eyewear. Anytime you have blood that's spurting, childbirth, you want to make sure you're completely covered. Gloves are only used for starting an IV. You don't need anything else. Again, if you are taking a blood pressure, they say no, you don't need gloves. If you're Measuring blood pressure, no, you don't need gloves. So some of the things, again, it all comes down to what you're comfortable with. You'll see a lot of the students coming out, they are being taught to use PPE appropriately based on what they're actually doing. So some of them may not start off the call with gloves until they find, that they may need it. They always do have them with them, but yeah, these new national standards are throwing everybody kind of for a loop. So some students, they put them on right away. Some students will kind of wait and see what happens. So antibacterial gels and hand soaps. Again, the CDC recommends just plain soap and water, not so much with the antibacterial soaps. They say it kills the good flora. The alcohol-based foams and gels are good, but it has to have a minimum of 60% alcohol to be effective. There are some other hand sanitizers and cleaners out there that are not alcohol-based, and again, they don't recommend those. If you have any open wounds, any cuts, sores, or anything like that on your hands, making sure that those are well covered when you're dealing with patients. So what is the department's responsibility? You've gotten a needle stick. What next? Obviously, your patient, go to the hospital. You want to check in at that same hospital where your patient is. Notify your chain of command here. We do recommend, like I said, that there is paperwork for you to recommend or alert the EMS system, but again, it's not one of those things that we can do a whole lot about. And this is one of the CDI forms that you can go ahead and fill out. All of these are online. And the other thing too, if you suspect a patient that you brought in might have some kind of communicable disease, we actually have 24 hours to get back to the crew to let them know, yeah, you just brought in a patient with bacterial meningitis, or you just brought a patient in with tuberculosis. And then at that point, we're supposed to contact you, bring you guys back in, and then do further testing. So, but you guys can also go ahead and ask if you're not sure whether a patient or not had some type of communicable disease. If you want to reach out to us, there's a form. Send it over to the EMS office, and Adam will take care of that pretty darn quick. We also have our exposure control plan for EMS providers. This really, it breaks down to that you should be wearing gloves whenever you have a patient with bodily fluids or blood. Making sure you're wearing gowns that are appropriate. You're washing your hands immediately. If you are exposed, you want to make sure you're, washing your hands. Let's see here, some of the other ones. It's small writing here. Making sure we're not recapping needles. We're putting sharps in the proper spots. And it goes on, never pass exposed needles from one person to another. Again, needles in the sharp container. So that's just, a lot of saying the same thing. Stuff that you guys should already know, stuff you should already be doing. This is the list of communicable diseases. If your patient has one of these, you will be notified. So if you take a patient with shingles or chicken pox that you're unaware of, hepatitis, mumps, tuberculosis, diphtheria, plague, polio, rabies, and pertussis, syphilis, any of those scabies. If the hospital, that's why it's really important that our hospital know who brings the patient in so that they are able to contact. It should be a call from our infectious control nurse, but it may end up being the charge nurse that will contact you. This is just to the recommended immunizations that you should have. Most people have had like chicken pox, but your MMR, when did you have your last immunization? DTP, your Hib, your polio, and hepatitis vaccinations. Does your department here go ahead and keep track of all of your immunizations for you? No? Probably not. Here's our other policy, pre-hospital communicable disease inquiry and related form. So if In the event of a significant exposure during a cardiac arrest, that patient shall not be a candidate for withdrawing care. And we had talked about that earlier. When seeking treatment, it is always best to obtain treatment from the same emergency facility in which you brought the patient. And then if you have an exposure to the patient whom you rendered emergency services, you need to complete the communicable disease form. Mainly what, and I talked to Adam after we started doing this presentation, because I'm like, really, that's not any of the EMS's business, what the results of it are. The fact that you even had an exposure really is not our business, and we kind of talked about it for a while, and he said, well, the reason why they want to know about it is if it comes down to a training issue. Do we need to go back out and re-educate? So at this time, I think that's probably, the best thing to make sure you guys are following policies, that the hospital knows about it or the EMS office knows about it. But that's all the EMS office is going to know. They will not know the results. They will not know anything else. Even when we have students that have situations. We've had a couple years ago, Aaron was exposed when he had the delivery where amniotic fluids sprayed all over. And then we had last year a patient who got spit on, or a student who got spit on by a patient. So even in those situations, we don't know about them. They fill out the paperwork, they send it in, and then we put them directly in contact with the infectious control nurse. So it should be completed, mailed back. We're not using really snail mail anymore. You can email it, you can scan it and email it, or you can fax it. Just so you guys know, though, when you fax stuff like that, that means that's sensitive information. Even though the three of us are the only people that maybe have access to that fax machine, there's a lot of people that come in and out. My recommendation is to scan it and email it just so that it...
We have 24 jobs and about 2 or 3 female unable to walk. 24 jobs, 24 jobs. About 2 or 3 female unable to walk.
You don't need to run through them, just... Yeah, so as far as the sheets are concerned, even bringing them directly over if you are sensitive and it's sensitive information that you don't want out there, and handing those directly to Adam, or if Adam's not there, myself, then one of us will go ahead and take care of it. So, and this is a form, again, that you can go ahead and use. Name, date of the exposure. They do want a run report with this so that we can kind of tie back to the patient if necessary. So make sure all that's there if you can get it. If you guys can't give us run forms, then just let us know. We can go, Adam can go into the system and pull some of those run reports, but at least you know the number. That's going to be the most helpful. So, communicable disease reporting, infectious control hospital reporting. Again, another policy here. Just basically states that if you guys bring in a patient, we need to notify you of, and how we're going to do it needs to be done within 24 hours. And the department will talk to the infectious control nurse or the highest ranking officer, manager in our department. The EMS department nurse, EMS coordinator, infectious control nurse will generate a communicable exposure form to see if any other testing is actually needed. And then it'll follow up with what any of the physician guidelines are said to be. You guys should be tested for your N95 masks, spit tested once a year for N95 masks. Does that happen here or no?
Yes.
Perfect. So, all right. Quick little video on donning and doffing.
Hold the respirator in the palm of your hand with the straps facing the floor. Place the N95 respirator on your face, covering your nose and mouth. Hold the bottom.